Well, hey, it's John Halamka, president of Mayo Clinic Platform, and thanks so much for having me today. I've been asked to speak for a few minutes on the future of AI and augmented human decision making. Where do you think the future is going to be? And I don't mean 10 years from now. I mean, say 6 quarters from now. What are some of the technologies you should be ready for? What are some of the caveats? What are some of the concerns? So let's start off with remember, machine learning and all these various technologies that are used for augmented human decision making are math, not magic. And so the question we ask is, what are the problems we can solve by having some of these advanced mathematical algorithms help us find signal in noise, help take vast sums of data and then reduce it to something that humans can understand? Well, let me take a couple of examples, some clinical, some supply chain, so we can at least give you a sense of what's coming. So here's a challenge. In complex signals like ECGs, 12-lead tracings of your heart, there are human interpretable patterns, but then there are subtleties that can only be detected by a machine learning type algorithm. Mayo Clinic has now finished and verified about 14 different algorithms that can look at such a heart tracing, either one gathered in a hospital or even something from your Apple Watch, and can diagnose disease, predict disease, can look at progression of disease, and can do so in a way that a human can't. Again, it's just pattern recognition based on millions and millions of data points. Oh, well, that's kind of interesting. So you're saying there's mathematical approaches that can take more inputs than a human can possibly comprehend and turn that data into wisdom and action. Well, if that happens clinically, well, what might we see from a administrative, financial, or supply chain perspective? Think back on the early days of COVID, and we had a question. How many patients needed what supplies in what location? And those could have been ventilators, or they could have been antibodies, convalescent plasma, or various kinds of other medical interventions. One of the problems we had is we just didn't have good visibility of the data. There was, in this country, very little linkage of the clinical information in electronic health records with supply information in various kinds of procurement systems. So it's interesting that as we look to the next 6 quarters, there's a lot of talk about instrumenting the United States healthcare system for better situational awareness. When we have the next big thing, whether it's a pandemic, a flood, a fire, or whatever, shouldn't we be able to say who needs supplies, who has supplies, and through that transparency, then be able to better allocate supplies for a supply-demand match? And that kind of thinking, certainly that's government agencies talking about that. Many government, academic, and industry collaborations have talked about doing a better job when that next mass casualty, that next pandemic, that next event occurs. So I think you're going to assume that we're going to get more novel data and then use techniques like machine learning to look at that novel data and help us with decision making. Always augmenting human decision making, not replacing humans. All these models that I've been talking about depend upon good quality training data. And that is, if we're going to train cardiology algorithms, we need millions of cardiology data points. If we're going to train supply chain, we need millions of supply chain data points. You can look at the sources of data. Well, Mayo has some pretty incredible sources of data. 10 million patients birth to death, their lifetime experience of healthcare. We certainly have all our procurement supply chain data. But is it enough? Even if we have millions of data points, is that going to be sufficient to create algorithms that help us with situational awareness or knowledge discovery for the country? And the answer is it's probably not enough. Just look at Mayo data. We need what's called a federated approach or a distributed data network. Mercy, you may know, 2 months ago, signed an agreement with Mayo so that we will be doing algorithm development and validation together. They're bringing 15 million patients and their birth to death experience. 2 months ago, we also signed an agreement with Sheba in Israel, and they're bringing millions of patients. We're talking to other organizations around the world about joining federated approaches to look at data and develop and augment human decision making. And so I tell you that because we hope, today, 10 million patients, but by the next year, we'll have probably about 100 million patients, total experiences that we can use to look at predictive models and new care pathways and new kinds of treatments or interventions. But here's a challenge. And of course, I'm making this up. But imagine we take this collective data from Mayo Clinic that represents the best healthcare for Scandinavian Lutherans. I realize we see many more than Scandinavian Lutherans, but take the data of Mayo, develop an algorithm, and then use it in rural Georgia. Is it going to work? Is it going to be fair? Is it going to be biased? There is a lot of work one needs to do on these algorithms to make sure they're fit for purpose, not only today, but a year from now. And let me give you some examples. So suppose that we developed an amazing telemedicine algorithm in January of 2020 based on all the people who were using telemedicine in January 2020. And then we deployed it in April of 2020. Well, I think you'd recognize the underlying pattern of healthcare delivery, the number of people receiving telemedicine services, the underlying data itself radically changed. And hence, this is what we call data shift. You can't just use an algorithm of the past and presume it will continue to work in the future. So we need to look at novel sources of data outside Mayo Clinic. We need to monitor algorithm performance over time. We need to continually ensure that whatever we are creating is fit for purpose for the population and the geography in front of us. Now, as we do all of this, you recognize technology will continue to accelerate. And this means that we're going to have more and more things instrumented in generating novel data that we can use in models. Think back just a decade or two ago when Walmart first suggested that they use RFID technologies for pallet and item tracking. And everybody thought, oh my God, that's going to be incredibly hard and maybe impossible to implement and track. And today, of course, it's a requirement of doing business with Walmart. So we're going to see more and more kinds of telemetry, more and more kinds of patient tracking, equipment tracking, novel sources of data that tell us a lot more about who is using what for what purpose in what location. And that's going to inform a fair amount of our algorithm development. So it's a very exciting time. I think we have this interesting combination of technology is good enough to gather data and to help us produce these models. Policies, government policies, FDA policies about what gets regulated, what can be used for what purpose, those are maturing. And culturally, I think we're certainly seeing in this post-COVID era, more and more stakeholders, providers, patients, pharma, payers, all recognizing that we all suffer data overload. And unless we have algorithms sifting the signal from the noise, we're not going to get through the day. So I think in sum, what this means is that you can assume that your workflow, your jobs will be supplemented by models and algorithms that give you situational awareness and help you with decision making. It does not mean by any stretch of the imagination that we'll have fewer humans, fewer professionals, less human direct decision making. It just simply means in the time of the Great Resignation and the Great Realignment, in times of supply chain challenges and inflation, that if we're going to get through the day, we're going to need all the tools at our disposal to make all of us more productive, to make all of us practice at the top of our license, so to speak. So there you go. Mayo Clinic Platform will be there helping you with the tools and the building blocks, the data curation, the algorithms, their validation, and navigating workflow integration. And that's the reason that Mayo Clinic Platform was founded. Ultimately, make our practice, all our sites and shields better. Help us capture Mayo Clinic knowledge, create new revenue models and opportunities, and then ultimately affect healthcare globally. So I look forward to working with all of you, exploring the future together, and I can assure you it will be a bright future. Thanks very much.